Hi, everybody. I'm going to give you a small talk on regenerative medicine. This was planned for the Kerala chapter IAPMR, CME, and Waynad this year. Due to events, it didn't happen. But today's topic is regenerative medicine. What is regenerative medicine? Basically, it's application of agents to stimulate repair mechanisms and restore function in damaged tissue. Who needs it? Anybody with a degenerating body, and none of us are getting younger. Why do we do this? To improve quality of life. How? There's 4 ways that we're going to discuss today. PRP, which is platelet-rich platelets, ozone, prolotherapy, and stem cells. Is there any science to it? Well, that's what we're here to find out. So nobody just wakes up with a disease. We all slowly go from a healthy state to a disease state, progressing through pre-disease states. Like you can see in these leaves below. Nobody just wakes up with osteoarthritis or myofascial pain. They slowly degenerate until they get to the point where the disease manifests. There's a whole degeneration cascade that follows with myofascial pain syndrome, which encompasses the musculoskeletal domain of these issues. That progresses to mechanical enthesitis, which makes myofascial pain worse, and it can get so bad that neuromusculoskeletal manifestations occur, at which point psychiatric or psychological symptoms start to manifest. And psychological manifestations can lead to depression, which eventually manifests as fibromyalgia. So they have myofascial pain, mechanical enthesitis, and now they have fibromyalgia as a diagnosis. Or radiculopathy, mononeuropathy. Fibromyalgia makes myofascial pain worse. Radiculopathy makes myofascial pain worse. Enthesitis will eventually lead to osteoarthritis, which makes mechanical enthesitis worse, which makes myofascial pain worse, which can make radiculopathy and fibromyalgia worse if in fact a person has those, but you can see a vicious cycle starting to emerge. Radiculopathy, untreated or poorly managed, will eventually lead to cervical spondylotic myelopathy or lumbar canal stenosis, and eventually makes myofascial pain worse, which perpetuates the cycle. All these will eventually end up in chronic pain, as you can see. And this is how people end up with chronic pain and degenerative problems. They don't just wake up with it. They slowly degenerate into these states. So conventional management, which is not regenerative therapy, is done by most of our colleagues, the paramedicals like therapists or the average general medicine, neurosurgery, orthopods. And it consists of self-exercise, get up and walk, lose some weight, control your diet, that kind of stuff. If the pain is really bad, maybe some NSAIDs like muscle relaxers or ointments also. If it's not controlled or you have contraindications for those, physical therapy modalities are an option. And if those don't work, well, then we can escalate into steroid injections, with like myofascial trigger points to get injected, epidural injections or facet joint injections. And finally, if we can't suppress the inflammation and you can't heal the person, maybe just go and destroy. So radiofrequency ablation is destruction of those structures that are responsible for sending the pain signals. I think you can see there's a problem here. We rapidly escalate into destruction, and beyond destruction, we don't really have many options as far as conventional management. And sadly, because of this kind of management, we push people into a state where they end up with chronic pain. Regenerative agents are a little bit different. Dextrose prolotherapy can cost about 40 to 150 rupees for the material, and then how much your provider charges you. It's typically 4 sessions over 8 weeks. Platelet-rich plasma, 4,000 to 15,000 rupees, depending on where you're going to get it from. Some places might charge you 20,000+ rupees. Part of this will be for kits that are used to get the sample. The other part will be maybe where you're getting it, who's giving it to you. But as far as our blood bank goes, to process this. It costs about 4,000 rupees for the spinning and the tubes. There isn't great evidence on how many injections a patient needs. Ozone, the machine will cost about 50,000 rupees, and then how much the care provider charges you will be set by them. Again, we don't really have a specified frequency and duration for this kind of a treatment. And the last is stem cells, which can cost anywhere from 1 to 10 lakhs, depending on what culture you've got and who's providing it for you. The benefits are unspecified. On the duration side, duration is unspecified. How do all these things work? Prolotherapy stimulates the body's inflammatory cascade, thereby promoting healing. PRP releases bioactive proteins, which stimulate the body's ability to heal. Ozone increases ATP and 2,3-diphosphoglycerin, which increases the release of oxygen in ischemic tissues, thereby promoting healing. And stem cells increase the expression of CD73, 90, and 105, and then also have the ability to differentiate into osteoblasts, chondroblasts, and adipocytes. Who do we not give these to? Prolotherapy is typically contraindicated in acute infections at the injection site, like a cellulitis, etc. PRP is contraindicated in critical thrombocytopenia, hypofibrinogenemia, septic shock, acute and chronic infections, chronic liver disease, like anticoagulation therapy. Ozone is contraindicated in bleeding dyscrasias, anemias, acute mental illness, and poorly controlled diabetes. Stem cells are contraindicated in genetic diseases like neurofibromatosis, tuberous sclerosis, cystic fibrosis, muscular dystrophy, metabolic disorders. And then when the life is impaired or threatened, so major organ damage, cancer, infection, HBV. The evidence about regenerative medicine is as vast as the ocean and wide as the sky. So for the sake of this talk, we're going to keep it to just two domains: myofascial pain and osteoarthritis knee, which is pretty much the domain of physiatrists. Here's a systematic review meta-analysis on prolotherapy that had 837 patients. Prolotherapy was equal to PRP for pain at the 6-month time point, but inferior for stiffness. It was useful in osteoarthritis knee with a level 1B evidence, and useful people with limited alternative options. Osteoarthritis, ozone in the knee. Systematic review. This one didn't have very good methodological quality for the studies they pulled up, so it was very hard to conclude if there's efficacy of other treatments. But we do know from all these studies that it's safe. It has good pain control and functional recovery in the short and middle term. Osteoarthritis and stem cell. So bone marrow stem cells, derived exomes, can effectively promote cartilage repair and extracellular matrix synthesis, as well as alleviate knee pain in osteoarthritis rats. So to summarize this, PRP is equal to Prolo with a level 1A evidence. Prolo plus ozone is equal to Prolo, level 1B evidence. Bone marrow stem cells promote cartilage regrowth, and ozone is good for midterm pain. When we look at myofascial pain and prolotherapy, here's a systematic review of 4 studies of 344 participants. 2 studies showed a 50% reduction in pain or disability, but there was conflicting evidence regarding the efficacy of prolo in reducing pain and disability with chronic low back pain. Myofascial pain and PRP versus control at day 5, the PRP group had a 58% pain reduction as a difference versus at day 14, where they had a 41% difference in pain. And of course, these guys were better for pain, not worse. Intramuscular injection of PRP was successful for reducing myofascial pain. Myofascial pain, ozone, lidocaine, and dry needling. So in the short term, all these were significantly effective, but the ozone and lidocaine groups were better than the dry needling group. And there's a significant decrease in VAS at 4 weeks follow-up that confirmed this. Here's a systematic review on ozone and myofascial pain. 6 trials, 717 participants. No significant pain relief at 3 months, but significant relief at 6 months compared to steroid and placebo. Ozone and low back pain systematic review. We have 7 studies here comparing to discectomy, steroids, or exercise, and there was improvement in pain functional scores with its application. So ozone is good for back pain. Stem cell back pain meta-analysis. So we have 21 studies, PRP plus mesenchymal stem cells showed level 3 evidence. Mesenchymal stem cells and PRP may be effective in managing discogenic low back pain, auricular pain, facet joint pain, sacroiliac joint pain, and variable evidence in favor of these techniques. So to summarize myofascial pain, ozone with lidocaine is equal to PRP with level 1B evidence. PRP or Prolo both reduce pain. Ozone helps for pain at 6 months with level 2B evidence. Prolo is better than control if given with ozone, level 2B evidence, and mesenchymal stem cells are helpful. Having said all that, when do we want to think about using all these things? So conventional care, which we discussed earlier, is not regenerative, but you still have to follow those kinds of things. The patient should be doing a home exercise program. They should be trying to modify their activity levels and increase it as tolerated. They should be doing weight loss and diet and education. They should be looking at ergonomics. They should have an explained expected reduction over time. This is probably the most important thing we can do for a patient. You see, if a patient comes to us and we tell them this injection will help, and they don't get better, they're going to want to know why. So if you say, with this injection, we expect a reduction in pain by this much in this much time, and they get it, they know that you've informed them and they know why they're experiencing what they're experiencing. If they don't, they know maybe they need more injections or something's gone wrong, but you've given them information to work with rather than just a blanket statement. So when you do all these things, you can have the patient get better, at which point just continue the same. And they really do have to work on posture, weight loss, activity, all those things. If they're not getting better, think about prolotherapy first. If you have signs of degeneration, especially in a joint, think about PRP. If it's still not getting better, look at stem cells, etc. And if it's still not getting better and they're not a candidate, otherwise, then you go and get surgery. So the question people ask is, I've been doing this for so long. I never used any of these things. Why do I need to now? Why should I bother using this information? See, the thing is, you do the best for the person in front of you. And if not, somebody else will. Thank you.